Thanks very much. So I'll be talking to you about high submuscular reservoir insertion. These are my disclosures. I do have a consultancy role with Coloplast, which is obviously an implant company. The other disclosure is that I was asked to make this presentation, but in fact, for a vast majority of my virgin cases, I still put the reservoir in the space of Retzius. That's how I learned to do it. That's what I do. But the issue is, why consider another placement? And I think this publication by Gerard Henry is key, again, reminding us about how close the vessels are, that danger is not far away. So if you're going to put the reservoir in the space of Retzius, you have to do it perfectly, because you can cause all kinds of problems. Well, herniation that was talked about, this can happen with the space of Retzius as well. This is a publication from Steve Wilson and I going way back when. Especially if you're not deep enough and the patient is coughing, you could have the herniation. This is also if the reservoir is placed a little bit laterally, it will put pressure on the iliac veins, and you will have possible venous thromboembolic events. So in the robotic era, remember that curtain is taken down, so everything becomes the same. Yes, the space of or the retropubic space is rather there, but the colon and everything else is not far away. We know that in Europe for many years they did place the reservoirs in the peritoneal space. So the fact that the reservoir is in the peritoneal cavity per se is not a big problem. We were talking about this many years ago with Ricardo Munarriz, and in fact a paper came up, which I'll show you in a minute, showing that reservoir will be sitting together with the other contents of the abdominal cavity. So this is from Daniel Osmanov, who had an excellent presentation at the UCI conference recently, basically showing that bad things can happen during intra-abdominal reservoir placement. You can see that paper in the far left from Dr. Garber showing the reservoir in the bladder. This is actually from our own publication. This is actually not a bad thing. This is the first time, and we published this is the first paper showing that when you put the reservoir in the traditional space of Retzius in the post-Raup robotic era cases, that reservoir is sitting possibly with the bowel contents, in this case right on the sigmoid. And not a big problem, so you could just reposition it if in case there's a diverticulitis or a problem in the future. But this is something you never want to see, and it's a rare thing. This is a publication that I wanted to include, just again, from Dr. Osmanov's presentation, showing that yes, bad things can happen if you are purposely putting a reservoir in the abdominal cavity. Again, this is a larger version of that paper that I mentioned from our group, the fact that the reservoir will be sitting on the colon. So Alan Morey, my good friend Dr. Kara, referenced this paper. Alan Morey popularized the high submuscular ectopic placement. What you see here is the Forster clamp, which is a super long clamp. Now, I will tell you that when I talk to Alan, who does probably more of these than most other prosthetic surgeons, I said, look, when I do this, I use the ring forceps. And he says, that's a good thing, because we also switch back from the Forster, because the Forster is very long, and especially if an inexperienced fellow or resident is doing it, it is not difficult to damage the bowel and cause real problems. The placement is very easy, and I'll talk about that in a second. And here you could see that the satisfaction rates are very high. In fact, in terms of the palpation of the reservoir, which can be an issue in thin patients, still about 40% of surgeons could feel it and 40% of the patients. But all in all, if you look at the bar, he says, how much does feeling the balloon bother you? The vast majority said it doesn't bother them, and the satisfaction rates are, in fact, very high. This is, again, courtesy of Danyar and Dr. Steve Wilson, who show that placement of devices, these reservoirs, is very easy. When you use that same infant lever and lift up the fascia, you could just go very easily in that space. The caveat that I will add, again, talking to Al Morey, is that this is a scenario where you will have a higher chance of reservoir herniation, so he has switched to making a separate incision, which again, for people who put these devices through an infrapubic incision, is very easy. And if you make that separate incision, he's not really seeing the problems with the herniation. Now, one quick thing, even with these approaches, if you underfill the concealed reservoir, this photo is from my friend Ron Wang, who shows that if you underfill the conceal, it can fold on itself and can develop develop weaknesses. You can also have migration of the reservoir down, calling the telephone cord problem. So again, it's all about how well you place it, how high it is, and then how you secure it. But I think the take-home message is that high submuscular placement is, in fact, very spaced. It is a critical technique for less experienced implanters, because if you do get into problem, the problems are minor. And in the words of Steve Wilson, you don't get into bleeding that you can hear, which is not a good thing. And it's a major asset in the hostile pelvis. Thank you so much.